Good afternoon, guys. My name is Chelsea Gregory, and this PowerPoint presentation summarizes my BSN Practicum project. I focus on reducing falls through education. Falls tend to be the most adverse event during a patient's hospitalization. It leads to increased healthcare costs, preventable injuries, and increased length of stay. So, introduction. Again, patient falls remain a significant patient concern. Falls can result in injury, increased length of stay, higher healthcare costs. This project focuses on improving staff knowledge of fall prevention interventions. Education was provided to staff on a medical surgical unit that I work on through a monthly meeting, through stand downs during huddles, and through just like personalized education and questions asked at different points in time. So, objective one, the overall goal was to reduce patient falls through education and increased awareness. I took the time at the beginning of this project to review different evidence-based literature on fall preventions, analyzed like unit data, identified trends, identified fallouts, and identified things that were just being missed. I also compared the unit outcomes to national benchmarks. I compared our unit falls from January to March or April, and then I compared them to national benchmarks for, nationally. I also identified the best practice interventions and then established evidence-based foundation. Goal two, I developed two and three, I developed staff education on fall prevention. And then I also, for objective three, evaluated staff knowledge on the interventions. I educated nursing staff, like I said, on several different occasions. They did participate in like a question and answer session, a discussion session to discuss barriers. For example, one that we really honed in on and identified. Patients go down for X-ray, CT, MRI, anything that requires them to be off the floor, surgery. They come back, they are automatically at higher fall risk because of sometimes the medications that they're given. They were high fall risk before they left the floor. And so they come back, transport, plugs in the bed, and they go. They don't, know the patient's fall risk. They don't automatically set the bed alarm. They don't drop the fall mats. They don't replace their personal items. And so one of the key things that I have identified as ways to keep patients safe are to evaluate constantly on an hourly basis, hourly rounding, is to assess their pain if they have to use the bathroom, if their personal possessions are in place, if they have their call bell within reach, if their bed is in the lowest position, if the bed alarm is set. I also evaluated compliance with the fall prevention measures through unexpected audits on the floor, random checks of different patients just to see if specifically the moderate to high fall risk patients, if all of their interventions are in place. And if they weren't, then I again provided individualized education. Completion strategies with evidence. Like I said, I conducted a literature review. I reviewed the facility fall prevention policies and procedures. I also evaluated the unit fall data and contributing factors that may lead to increased falls. And also I evaluated things that we were doing well. I just didn't look at the bad, I looked at the good too. I collaborated with my mentor and leadership team. And I also developed evidence-based educational materials. I created a PowerPoint on staff education presentation, and I also developed a quiz that I gave the staff members after the presentation was done. 24 of 39 employees completed it at 100%. No questions were missed, which lets me know that the unit knows how to keep the patient safe, but through tunnel vision, alarm fatigue, rushing, little to no time to do anything, patient acuity, it was where we kind of fell out. And then I also attempted to develop a badge buddy, which is a little card that connects to your badge. I did run into complications with getting that approved. So I went to a badge pin option, which is just like a little, it's similar to a daisy pin. It just connects through your sticks, pokes right through your badge. And they were yellow socks that says, please don't fall for me. Um, Through this, I evidence was attendance records, surveys, quiz results, educational materials, and the badge pin implementation. Specific outcomes for the nursing unit, I increased patient awareness of fall risk factors. I really educated the nurses on the importance of submitting a honest fall risk assessment. It's easy for you to say a patient is a low fall risk at home, they ambulate independently. Sometimes patients come in, they're not honest about if they've had a fall recently. And so we have to take into all accounts and all factors of medications, blood pressure medications, sedatives, narcotics, anything that'll make them sleepy, melatonin. All of these things factor into whether they have oxygen, telemetry, STDs connected to them, or if they have IV tubing that's connecting them to a pole that's connected to a wall. They have to take into account all of these things, mental status, whether they're alert and oriented, and of course, age, all add up to, or even whether they have on glasses or hearing aids. All of these things are there and have to be accounted for when doing the patient fall risk assessment. I also place a greater emphasis on bed alarms and hourly rounding. If we round hourly, there is no reason why a patient should not have their possessions. There's no reason why they should not have water. There's no reason why they should be trying to get up to use the bathroom unassisted if we go in there every single hour. And if a staff member is present and makes their presence known, throughout the shift. Um, Again, I enhance staff engagement through um asking the staff what are barriers, what are fallouts, what are things that we can improve on. Positive note, we had 10 falls from January to about March or April, 4 with injury. We did sustain 2 falls recently. However, neither of them had an injury, and every single fall intervention was in place that could have been in place. The first fall occurred where the staff member was attempting to ambulate the patient to the bathroom. His knees buckled. He had a gait belt on. He had the fall mat in place. He would utilize a walker. Staff member was in the arm's reach. He just was simply lowered to the ground. And then the other intervention was, well, the other fall was where the patient had the RPM in place, which is the remote patient monitor. They had the bed alarm on, fall mats in place. Um, Bed is at the lowest position. All their personal possessions were within reach. Call bell was in place. Patient was just confused, very fast, got out of bed, ended up sitting on the bed, on the fall mat near the bed. So that, yes, 2 falls occurred. However, every fall intervention was in place. Staff were in the room. Our trackers showed that staff were there hourly to assist with patient needs. Application of the project in practice. So, this supports, evidence-based practice. It promotes ongoing staff education and competency. It ensures consistent, you know, fall risk assessments, and outcomes can be monitored through quality improvement. So the value of this project has strengthened my leadership as a charge nurse, as someone of leadership on the unit, as someone that is a resource for others, as someone that is a primary preceptor. It has strengthened my ability to utilize research and evaluate and apply evidence-based practices in real life. It has also increased confidence in staff education and mentoring. It has also increased staffing confidence with what they already know and just taking it and applying it in real life. This has reinforced our commitment as a unit to patient safety and professional growth. Thank you guys for watching. This again summarizes my BSN Practicum project on fall prevention. Thanks again.